Dear colleagues, a very warm welcome from my side to this webinar. My presentation starts with a short overview about influenza diagnosis in general, and I also want to show you two examples from the daily practice. Secondly, I want to focus on presenting the results of our field study, investigating reproductive performance of pandemic influenza-infected sow-herds before and after implementation of vaccination. So let's start with the influenza diagnosis, which can be divided in direct and indirect detection methods. The most commonly used material for direct detection are either nasal swabs from live animals or trachea and lung tissue samples from dead animals. Recent studies have focused on investigating new approaches like oral fluids, oropharyngeal swabs, other skin wipes, or environmental samples. Comparison of the different materials revealed that for direct detection, pooled group samples like the oral fluids or the other skin wipes or environmental samples are a good option to individual pooled samples like pooled nasal swabs. However, if you aim at performing a virus culture, you should prefer individual samples like nasal swabs or nasal wipes or oropharyngeal swabs. There you have the highest chance of obtaining an isolate compared to group samples or compared to environmental samples. With regard to the indirect detection, antibodies can be a result of vaccination, of an infection, or they can be maternally derived. Several ELISA tests are commercially available on the market. However, with influenza A virus ELISAs, you can't distinguish between the different subtypes. The hemagglutination inhibition test is a subtype-specific test, and it's most commonly used for routine diagnosis. However, you have to keep in mind that cross-reactions can occur between the different subtypes in the hemagglutination inhibition test, which complicates the interpretation of the results, especially when pigs are already vaccinated or when different strains are present on the farm. Additionally, the performance of the hemagglutination inhibition test strongly depends on the antigenetic match between the strains circulating on the farm and the strains used in the test. The serum neutralizing test is a very costly test. It's also labor intensive. It requires the cultivation of the virus, and thus it's not used for routine diagnostics. Now I want to show you two examples. One example from an acutely infected herd and one from an endemically infected herd. So let's start with the anamnesis of the acute outbreak. The case herd was a piglet-producing farm with 180 sows. It was located in an area with a low pig density in southeastern Germany. The farm had no history of influenza vaccination. The farmer reported fever and coughing in sows in the gestation unit, and according to the farmer, approximately 30% of the sows in the gestation unit were affected. 3 sows had died without showing any obvious clinical signs, and additionally, sneezing and coughing was reported in suckling piglets. 2 weeks later, reproductive failure in terms of abortion, stillborn piglets, and weak-born piglets occurred, and also the return to estrus rate increased. For diagnostic workup, we collected blood samples from sows, and we also collected nasal swabs from acutely infected sows and nasal swabs from suckling piglets. On this table, you can see the results of the hemagglutination inhibition test. There were antibodies present against avian H1N1 and against pandemic H1N1. Antibodies against the other subtypes were negative. As I have already told you in the beginning, cross-reactions between the avian H1N1 and the pandemic H1N1 can occur, which complicates the interpretation of the results in this case. However, we had 3 cells, here marked with a red circle, where antibody titers against pandemic H1N1 were at least 2-fold higher than antibodies against avian H1N1. In this case, this was an indication for an infection with pandemic H1N1. Our speculation about the pandemic H1N1 infection was also confirmed by PCR analysis. The subtype-specific PCR revealed the presence of pandemic H1N1 in one sample, and this sample originated from suckling piglets. It was a pool of nasal swabs from suckling piglets. However, you can see that even in an acute case, not all samples are positive. Here in this case, just 3 out of 5 samples were positive, and subtyping was only possible in one sample. We couldn't subtype the other 2 positive samples due to a low virus load, here represented by a high CT value. So high CT value means low virus load. So in this case, serology already gave us a strong hint that pandemic influenza infection might be involved in the clinical problem, but unfortunately, such cases are really rare. Therefore, I want to present you the second example. It was a farrow to finish herd with 250 sows. It was located in an area with a high pig density in southwestern Germany. And the sows were vaccinated with flu 3 at 100 days of gestation. The farmer reported occasionally occurring fever in the sows in the gestation unit, and the return to estrus rate has increased during the last 4 months, formerly 10% to 30%. Additionally, respiratory distress was observed in the nursery and in the fattening unit in terms of coughing, sneezing, and dyspnea. Again, we took blood samples from sows, and we took nasal swabs from suckling piglets. In this case, we didn't collect nasal swabs from sows because there were no acutely diseased sows present at the time of our herd visit. However, we collected oral fluids in the nursery and also in the fattening unit. On this slide, you can see the results of the Hem agglutination inhibition test. Antibodies were present against all subtypes. And if we look at the antibody titers against avian H1N1, H1N2, and H3N2, they were representative for a vaccinated herd. So in this case, serology really gave us no indication that pandemic influenza might be involved in the clinical problem. However, we could identify pandemic H1N1 by subtype-specific PCR again. One sample was positive in the subtype-specific PCR, and interestingly, the subtype-specific PCR was repeatedly positive in samples from suckling piglets. This is in accordance with previous study and also in accordance with reports from vets that for direct detection of influenza, suckling piglets are the preferred age group to sample. So if we had just relied on serology in this case, we would have missed the pandemic influenza infection. However, you can also see that for the direct detection, a huge sample size is needed. In total, we took 7 pooled samples or group samples, and only 3 of them were positive. And again, subtype-specific PCR was only possible from 1 sample. So as a summary from the influenza diagnosis, you can say that especially for the direct detection and particularly for the detection of pandemic influenza, you need a high sample size and you should always combine both serology and PCR. So let's proceed to the results of our field study. Several case reports and also several case control studies indicate that influenza virus can induce reproductive failure. However, this has not been proven under experimental conditions so far. And thus it might be speculated that for the induction of influenza-related reproductive failure, additional cofactors, infectious ones or non-infectious ones, are needed to reproduce the clinical signs. Therefore, we have performed a longitudinal field study investigating reproductive performance of pandemic influenza-infected sow-herds, and the results of our studies have been published in a peer-reviewed journal in the official journal of the European College of Porcine Health Management. We had the great opportunity to choose from a large pool of herds, in total 315 sow herds. Those herds were part of an extended field study conducted to achieve market authorization for the vaccine Respipork Flupan H1N1 in Germany. Requirement for the vaccine approval in this pre-registration trial was either the detection of pandemic influenza direct by PCR or indirect by hemagglutination inhibition. The herd attending vets received an observation protocol from us, and this observation protocol was divided into 3 parts. In part 1, we collected farm-specific data, farm type, internal and external biosecurity, and the current vaccination scheme. In part 2, the clinical signs related to an influenza infection were qualitatively assessed. We assessed them qualitatively and not quantitatively, so not with a score system, because the focus of our study was to evaluate the reproductive performance parameters. In particular, we collected the return to estrus, the abortion and the stillborn rate, the piglets born alive, the pre-weaning mortality, and the number of weaned piglets per sow and year. Primary vaccination consisted on all forms of mass vaccination. The sows were vaccinated twice at an interval of 3 weeks, and the reproductive performance parameters were collected 6 months before implementation of the vaccination and 6 months after completion of primary vaccination. The primary vaccination, those 3 weeks, were not included in the data record. Farms were revaccinating again after 3 to 4 months. Based on the results of our questionnaire, we could only include 137 out of the available 315 farms. I will present you the exclusion criteria on the next slide. However, I can say that we really had to determine strict exclusion criteria because it was a field study, and under field condition you have various factors, infectious one and also non-infectious one, that potentially influence your reproductive performance. And as we wanted to reduce this bias, we applied very strict exclusion criteria. However, we were still able to analyze data from a total of 60,153 cells. In one third of the farms, we could detect the virus directly, so in only 1/3 by PCR. And in 2/3 of the farm, we had to rely on the results of the hemagglutination inhibition. I think this again emphasizes my former statement And I think you can also confirm it from your daily practice that the direct detection of pandemic influenza can be very challenging. Our exclusion criteria were in particular restocking of the sow herd, depopulation and repopulation, lack of vaccine compliance, and change of internal and external biosecurity. We did also not include farms with known co-infections at the beginning of the study. And with regard to farms where we only had a serology result, we did only include those farms if antibody titers against pandemic H1N1 were at least twofold higher than antibody titers against avian H1N1. The herd size of the included farms varied between 38 sows and 5,600 sows, with an average farm size of 448 sows. I think you can see nicely on this figure that the herd size varied enormously. However, this reflects the German pig reduction with larger farms in the eastern part of Germany and also in the northern part of Germany, and smaller farms in the southern part of Germany. Based on the results of our questionnaire, the majority of the farms were already vaccinating against other influenza subtypes. They used the vaccine Respipork Flu 3. So let's proceed to the results. You can see the clinical presentation. And in 2/3 of the farms, coughing and fever was reported. And interestingly, in almost 80% of the farms, reproductive failure was reported in association with the detection of pandemic influenza. On this slide, you can see the number of farms with influenza-related clinical signs in the respective months, here displayed or shown as red bars. And you can see that influenza-like clinical signs were observed throughout the year. This is in accordance with previous study where no seasonal influence on the occurrence of influenza was observed, and thus influenza turns out to be a problem throughout the year. So now I want to present you the results of the reproductive performance evaluation. We have the return to estrus as first parameter. On the left side, you can see the mean return to estrus rate before vaccination, which was 13.5%, and it was significantly reduced after implementation of vaccination to 10.18%. On the right side, you can see the data displayed in a scatter plot. So each dot represents a single farm. And on the x-axis, you can see the return to estrus rate before vaccination. And on the y-axis, the return to estrus rate after vaccination is shown. No change of the return to estrus rate was observed in farms that are situated directly at the diagonal. In farms below the diagonal, the return to estrus rate decreased after vaccination, and in farms above the diagonal, the return to estrus rate increased. So I want to show you one example. Hope you can see my pointer. This farm here had a return to estrus rate of 25% before vaccination, and it was reduced 5% after vaccination. You can see that the data again varied enormously between the farms. And this was the reason why we decided to go a bit deeper into data analysis. And we classified the herds according to their return to estrus rate before vaccination. So farms with a low return to estrus rate before vaccination were classified into category 1. Farms with a high return to estrus rate before vaccination into category 3. And you can see nicely on this table that the mean decrease of the return to estrus rate differed significantly between the three categories. This means that in farms with a high return to estrus rate before vaccination, the return to estrus rate could be reduced more significantly than in farms with a low return to estrus rate before vaccination. The abortion rate was only significantly reduced after implementation of vaccination from formerly 2.3% to 1.4%. With regard to the piglets, not only the live-born piglets but also the weaned piglets significantly increased in the time period 6 months after completion of primary vaccination. On average, farms could wean more than 1.3 piglets more per sow and year after implementation of the vaccination. Consequently, the pre-weaning mortality also decreased from 14.17% to 13.65%. The only assessed parameter in our study that was not significantly influenced by the vaccination was the number of stillborn piglets. I've shown you in a previous slide that the herd size varied of the included farms. And as the herd size can have a potential effect on the reproductive performance parameters, we evaluated this aspect in a linear regression model. And according to this linear regression model, no association was found in our study between the herd size and the return to estrus, the abortion rate, the number of stillborn piglets, piglets born alive, the pre-weaning mortality, and the piglets weaned per sow and year. We also asked ourselves if farms that were already pre-vaccinating against other influenza subtypes that were pre-vaccinating with respiratory flu 3 had a benefit compared to farms that were not using influenza vaccination before the implementation of respiratory flu pan H1N1. It is known from literature that despite cross-reactions in the serum neutralizing test between pandemic H1N1 and other subtypes, there is no cross-protection between pandemic H1N1 and the other subtypes. And this was also confirmed by our results because we found no association between pre-vaccination of farms against other subtypes and the majority of the assessed reproductive performance parameters, with the exception of one parameter. The number of piglets weaned per sow and year was significantly higher in farms that were already pre-vaccinating with respiratory flu 3. This condition might be explained by an improved colostrum quantity and also colostrum quality, and perhaps by reduced shedding of the cells in the farrowing unit. Thus, the results of our studies might indicate that with vaccination, both respiratory flu pan and respiratory flu 3, you can improve the conditions for the piglets in the suckling period. So to summarize, you can say that our study strongly supports the often described but scientifically so far not verified link between pandemic influenza infection and reduced reproductive performance. Additionally, the large number of farms included and also the large number of sows affected by reduced reproductive performance indicate that influenza infection can have a great impact on the swine production. In addition, with other studies, we found no seasonal influence on the occurrence of influenza infection, and thus influenza has turned out to be a problem throughout the year. With the exception of 3 farms, all farms could improve at least one of the following reproductive performance parameters after vaccination, in particular the return to estrus rate, the abortion rate, the number of live-born piglets, the pre-weaning mortality, and the weaned piglets per sow in year were improved. Remarkably, in the majority of the farms, not only one, but more than one of these mentioned parameters were improved after implementation of the vaccination with Respiriport Flupan H1N1. So now I'm at the end of my presentation, and I want to start. First, I want to thank you for your attention, and then I want to start with my questions. Paloma?
Yes, I am here. I already start the pool with the first one.
Okay, perfect.
Then you just need to go to the next slide and present.
So should I leave the presentation modus?
No.
You see that?
Move one. Your should be there. The question. Okay. Now you have it. The question is, how many of your herds are vaccinated against flu?
Okay, I have to read the question, or?
Yes.
Do the others see the question? No.
Yes. The others are seeing the questions and are already waiting. Okay.
Are they already? Should I read the question again?
Yes. You can.
Okay. So my first question is, how many of your farms are vaccinating against influenza? So you have 4 options to choose between 0 and 25%, 25 to 50%, 50 to 75%, or 75 to 100%.
And then 36% of the attendees says that they vote between 0 to 25%. 34% of the attendees vote vaccinate between 25 to 50%. Between 50 to 75%, 18% of the attendees. Between 75 to 100% of the herds, 12% of the attendees.
Okay, so there was a huge variation in the results. Honestly, this was what I have already expected. This also reflects the situation in Germany. Germany, we have a great discrepancy in influenza vaccination density between the different regions. For instance, in the northwestern part, where the pig density is very high, approximately 60% of the herds are vaccinating, in contrast to 30% in approximately 20%, only 20% in the eastern part, where we have a huger distance between the farms. I think that's the reason. However, you have to keep in mind that next to purchase of animals, next to trade of pigs, and next to aerosols from the neighboring farms, humans can serve as source of introduction for influenza infection in swine herds, particularly for pandemic influenza. Interestingly, we have observed an increasing detection rate of pandemic influenza in regions with a low pig density, and even in farms that were regarded as isolated, which had no purchase of animals, no purchase of semen, no neighboring farms with aerosol, so humans must be the only possible source of introduction. And I think you have to keep that in mind. So I will proceed to my next question. What is your preferred vaccination scheme for influenza? Is it mass vaccination every 3 to 4 months? Is it mass vaccination every 6 months? Or are you preferring a reproduction-orientated vaccination of the sows during gestation? Or reproduction vaccination during the suckling period?
Okay, I will end at the poll, and the results is like 53% says mass vaccination every 3 to 4 months, 21% reproduction-oriented vaccination of sows during gestation, 19% mass vaccination every 6 months, now 21, it moves, and then 5% reproduction-oriented vaccination of sows during suckling period. 53 3 to 4 months, 21 mass and reproduction before in gestation, and just 5% in the suckling period.
That's a nice result. We always recommend to perform a vaccination at an interval of a maximum of 4 months. From my point of view, it's not recommendable to extend this period to 6 months, especially not in areas with a high peak density, where you have a continuous high risk of introducing influenza through aerosols from neighboring farms. And in my opinion, it's also not advisable to perform a reproduction-orientated vaccination during gestation or even during the suckling period, because there you have a high risk of creating gaps in immunity, particularly when sows are returning to estrus and the farmer forgets to revaccinate them. And I think they are often forgotten to be revaccinated, the returning sows. So my preferred vaccination scheme is mass vaccination every 3 to 4 months. So 3 months if the infectious pressure is very high in a high peak density area, or 4 months is in most of the cases, or in many cases, sufficient. So my last question is, I have already stated that humans are a potential source of pandemic influenza introduction into sow herds. Are you in personal vaccinated against influenza? Yes or no?
45% said yes, 55% says no.
Okay, that's what I expected, to be honest. My personal opinion is that we should get vaccinated against influenza. With the evolution of the pandemic influenza in 2009, or with the emergence of pandemic influenza, the interspecies barrier between humans and pigs has completely disappeared. With the classical strains, there was an interspecies barrier. It was not that high, but at least it was existing, more or less. And we have observed during the last years quite often in parallel influenza-like clinical signs in pigs and also in the respective caretakers. So as pigs are regarded as mixing vessel hosts for genetic reassortment, and also due to the fact that influenza is transmitted more frequently from humans to swine than vice versa, we should serve as role models, we vets, and we should get vaccinated. That's my personal opinion. And now I'm at the end.